Dr. Plesner, you had said that to treat early would be better than to treat later, and so I guess that's going to come up later in the in the evaluation. But one of the things that I've always wondered is that about 15% of patients are found in stage 1, about 25% of patients are found in stage 2, and about 60% of patients are found in stage 3. So it looks like we just do and I think Dr. Morgan from the University of Arkansas for Medical Sciences brought this up and said it's almost, he called it, it's a scandal that, we don't find this earlier in the disease progression. And I was wondering, because Denmark has, a care for all, and I'm sure you got good records and that kind of stuff. What do you find it better than we do earlier, or do you have the same issues? And is there anything that that can be done that you can see to find it earlier before it progresses? Because it always is easier to treat, and you have a longer life if found early.
I think you are touching on a very, very important issue. It has been shown that in myeloma you have a clonal evolution during the course of the disease, where the disease often looks quite benign in the beginning, but all the subclones are there. They're present from the very beginning, and with time, with successive courses of therapy, the more resistant and more malignant subclones will emerge and become dominant and finally kill the patient. And I think that is the best argument we have for using the very best drugs we have to kill myeloma cells up front, when the more malignant, more refractory myeloma clones are small in number and perhaps have not developed resistance mechanisms, so we can eliminate them by early treatment. So I think the strategy that has been around in Europe, at least for many years, that one should be conservative and treat with simple drugs in the beginning and keep the more advanced drugs for later use. I think that is a wrong strategy. I think what we have, the data we have, suggests that we should bring the best drugs up front and do our very best to interfere with this clonal evolution that will eventually kill the patient.
Right. That's and how do what needs to be done in order to find it early? When it's in very earliest stages, like smoldering, and or a high-risk MGUS.
I think we need to create awareness about this among our colleagues. Many of the early signs of myeloma are quite subtle and are symptoms that you often find in the elderly population, like low back pain. And doctors see hundreds of patients with low back pain and not myeloma. And then suddenly one of the patients with low back pain has myeloma. So it's so difficult to be a general practitioner and to be able to make the right test at the right time. Often myeloma is overlooked for even a few years before it becomes a major problem for the patient and evidence to everybody that this is a very malignant disorder. So awareness among general practitioners, among patients, is a key to early intervention and greater success.
Well, thank you, Doctor. And Priya, would you like to?
Yes, Gary. We have a listener, person calling in from 718-983-6757. You're on air. Please ask your question.
Good day, Dr. Plesner and Cure Talk panel. This is Dana Holmes. Thanks so much for taking my call. Dr. Plesner, I'm a smoldering myeloma patient. I actually submitted this this round of questions, but I had a moment to call in, so I was grateful I was able to get through. I have high risk to progression features per the risk progression models, both the Spanish and the Mayo Clinic. The risk progression models that I guess everyone really uses at this point. So I would really welcome your thoughts about the Darzalex trials developed for high-risk smoldering patients. Do you believe Darzalex has the potential to be curative or produce a long-term preventive solution in this patient population?
I think Daratumumab will be a very important part of this solution, perhaps the most important part. I'm not sure if Daratumumab can stand alone. I like a lot the combination of Daratumumab with lenalidomide and dexamethasone because they play very well together. Lenalidomide is boosting the immune system. Daratumumab is taking, I think, advantage of that. So they go very well together. What we have been seeing is that after 2 years of treatment with the combination of daratumumab, lenalidomide, and dexamethasone, the patients, I'm speaking about patients with relapse refractory myeloma that are responding to the combination. We see that they become, after a while in complete remission, they become more and more worried about the side effects. And the side effects of the treatment comes from lenalidomide and dexamethasone. So what I could see was an initial period where the triplet is used with daratumumab in combination with lenalidomide and dexamethasone. And after 2 years or so, one could perhaps continue with daratumumab as a maintenance therapy. What is really going on in the patients, we cannot tell you because what we see is just that the signs of disease have disappeared. The M component is gone. There's no clonal myeloma cells in the bone marrow, and the patients are doing very well.
And these are this is the refractory and relapsed myeloma group?
This is the group where we have 2 years and more of experience. Yes.
Wow.
So for the smoldering myeloma, I think the result will be even better. But the balance between, I'm sure the Dara should be on all the way, also in the maintenance setting. But the duration of you could call it a kind of induction therapy with lenalidomide and dexamethasone in combination with daratumumab. What I see is that the side effects become more troublesome after a couple of years.
Because of the Rev and the Dex, the Revlimid and the dexamethasone.
Because of the Revlimid and dexamethasone, yes.
Do you foresee such a trial being developed for smoldering patients? Or is it too early because of the monotherapy trials really haven't been completely accrued yet?
I think we'll have to do the monotherapy first. But we know from the Spanish study, I'm sure you're aware of that, that lenalidomide and dexamethasone makes a difference as compared to watch and wait. You can criticize this study because the smoldering population was not very well defined because they used conventional X-ray to determine if the patients had osteolytic lesions or not, and we know that it's not sensitive enough because CT scans are needed to provide the best sensitivity. So probably in the Spanish study, we had patients with real myeloma with osteolytic lesions that could have been found by CT scans.
Mm-hmm.
But even then, I think what we have learned from the Spanish study, published by Mateos and her colleagues, is that treating myeloma early is a good thing to do.
Mm-hmm.
Before
that sounds exciting, because from a patient standpoint, from a smoldering myeloma patient standpoint, the watch and waiting is for the birds, to be quite honest with you.
Yeah.
Dr. Plesner, is there a way to determine who would respond to Darzalex before beginning treatment? Is there a way to test the cells to see if it would actually work?
No, I think you would have to jump on the treatment, jump into it.
Mm-hmm. Okay. And what about, is this a long-standing antibody, or do you, in other words, once you stop using it, do you lose the actual antibody? It doesn't remain in your body forever.
No, it disappears within a couple of months.
A couple of months. Okay.
Mm.
Well, thank you for that insight. I appreciate it.
You'll have to stay on therapy.
Mm-hmm. Which of the 3 trial arms do you feel would be most beneficial for the smoldering patient? I'm presuming it would be the intense arm, which is the long-term arm.
Yes.
I know they haven't been able to answer the questions yet, and that's why there are 3 trial arms. But from what I'm hearing throughout this discussion, it just makes sense that that intense arm is the one to stay on, to have this Darzalex consistently in your system, particularly if it doesn't remain in your body long term.
Yes, I agree that the continuous treatment seems to be the answer. We are all dreaming about cure of myeloma.
Yeah.
And I don't know what we need to achieve this goal, but definitely the early treatment of high-risk smoldering myeloma would be one area where you could be successful.
Mm-hmm. If a smoldering patient were to engage in this particular monotherapy trial, and down the road someone developed a trial combining it with Revlimid and dexamethasone, could a patient potentially cross over into such a trial? Or do you think they'd be excluded?
If you're on a trial, you cannot jump to another one. You'll be excluded. But if the treatment is developed and approved, then you can leave the trial without any problems and then go on an approved type of combination.
Okay. Dr. Plesner, thank you so much for your insight and for your time today. I very, very much appreciate it.
A great pleasure.
Thank you, sir. Enjoy Italy.
Dana. We have a listener calling in using 602-309-1177. You are on air. Please ask your question.
So, Dr. Plesner, my name is Robert Jameson. Thank you for being here this morning. I have two questions for you. Of course, one of them relates to the diagnosis part of multiple myeloma, and then the second one I'd like to talk about testing along the way after you're on Darzalex. So I was 58 years old when I actually initially went to my knee doctor, and he did a SED rate test and realized there was something wrong with me. He eventually put me back to my primary care physician, who did another SED rate test and determined the same thing. He sent me to a rheumatologist who did a SED rate test and decided I had MGUS, who finally sent me to a hematologist. The hematologist did blood testing on me and determined that I had an M spike and was just going to watch it as smoldering myeloma. Eventually, and this is about a 6-month period of time, my calcium level got to 20, and I wound up with hypercalcemia in an emergency room, and one thing led to another where they finally brought in the oncologist and was able to do a bone marrow biopsy and determined that I had indeed multiple myeloma. My question on this first part is, if my hematologist sees that I have an M spike and it's high, why isn't he compelled to do a bone marrow biopsy? I feel like I went from stage 1, or actually smoldering myeloma, to stage 3, which was where this was diagnosed, while I was being bounced around to specialists and wasted a lot of time and could have improved my overall prognosis. Okay, so that would be question 1. Question 2, because I became a myeloma patient, and I'm being treated at MD Anderson over in Gilbert here, which is great care. I'm grateful for them. I was put on a couple of different regimens. What worked best for me in the long run was Revlimid. Eventually, I had a stem cell transplant, and unfortunately, it failed after about 6 months. I have an IgA disease, and my kappa light chain ratio climbed within about a 2-month period. So they started me on Darzalex. I've had 3 infusions now, and my question on this part of it is, why do I have to wait for 8 weeks before they do the first blood test, at least, to see how my kappa light chain ratio is? So those are my 2 questions.
Yeah. Myeloma can be a very tricky disease to diagnose. When you see a patient with an M component, did you have a complete M component with a heavy chain, or was it just light chain?
Light chain.
Light chain only.
Yes.
Yeah. I think in Denmark we would do a bone marrow examination up front with a kappa light chain signal. And as part of the workup, we think that it is essential to use the most sensitive technique to reveal bone disease, which could be the reason why you developed the hypercalcemia. So in our hands, a CT scan of the axial skeleton is a standard of care. On top of that, we use conventional X-ray for the extremities of the skull.
Right.
So this will be with the bone marrow, our primary workup. And then we would look for evidence that this situation needs intervention, needs treatment. And if you heard me before, I think that early treatment is important to have the best results before you have emergence of more resistant and more malignant clones. So early treatment is the key to success. Why you needed to wait for, you said 8 weeks before you had testing of the kappa lambda ratio?
Yes, that's what my schedule shows. I'm being infused for every week for 8 weeks. And then after 8 weeks, they're going to do a test to see how it's working. And that's kind of my question. Okay. Is I'm just so not familiar with the drug. Why are we waiting 8 weeks? Does it just take that long before you?
We would do the testing of the M component or the kappa lambda light chain ratio on a monthly basis. That is every 4 weeks.
Okay. All right.
Just to make sure that we're on track.
So 8 weeks. 4 weeks would be early enough to see a change if there was going to be one.
Yeah.
And I guess I do have a third question. What do you think the percentage of efficacy is with all patients now? You know, I was never in trials and never really had refractory to anything. So, and I know this is a little bit of a loaded question, but what is the efficacy going to be for all patients on Darzalex? Like, what would make it fail right out of the gate? Or is
the experience we have from trials, that relates to patients that are heavily pre-exposed to standard therapy like image, lenalidomide, pomalidomide, to to proteasome inhibitors such as bortezomib and in some cases also carfilzomib. And also the majority have been transplanted. So what we know is that this heavily pretreated population of patients, and that we can achieve a response in about 1/3 of the patients. But if you are starting earlier on daratumumab, your chance of having a successful outcome is much better. I know that daratumumab is approved in the United States as a single agent therapy. Can you use it in combinations? Is it permitted now? Is it supported, financially supported by your system? The reason why I'm asking is that I think that daratumumab is doing great on its own, but it's much better in combination with lenalidomide or perhaps even pomalidomide.
In my case, what they're doing is they're doing the Darzalex with dexamethasone.
Yeah. Mm. So you were not refractory to lenalidomide?
No. The only reason they stopped it was, unfortunately, I had blood clots, and those turned into pulmonary embolisms, so they took it off. Yeah. It actually worked very well, and I was so close to the end of the therapy, they just decided to go ahead and move forward with the stem cell transplant.
Yeah.
So, no, I worked well with it. It just, and then, of course, afterwards, they tried to use it as a maintenance, but because it's so toxic, it was just beating up my blood numbers, and we just couldn't get them back. So that's when we decided to switch over to the Darzalex.
You know, I do have patients that have had complications on lenalidomide, like pulmonary embolism, but I put them back on therapy after a while with a combination of low molecular weight heparin and aspirin. I use both types of anticoagulants to prevent new thrombosis from developing. So I think it could be done in a safe manner to resume the lenalidomide dexamethasone therapy if you have daily low molecular weight heparin along with aspirin. So you are inhibiting the coagulation system in two different manners.
Yeah, that's interesting that you say that, because one of my comments to the oncologist was that they put me on lenalidomide, but they did not put me on any anticoagulants. So I was very susceptible to any of the side effects when it comes to that it was going to happen, and sure enough, it did. So only afterwards did they finally put me on warfarin to use as an anticoagulant. It was too late then, right?
Yeah, I'm not very fond of warfarin, but I think in your case you could safely resume lenalidomide dexamethasone if you have this dual anticoagulation therapy with low molecular weight heparin in combination with aspirin.
Yeah, it's a bit of work to get the anticoagulant rate correct, and it's finally they've taken me off of that now that I'm on the the dexamethasone or the Darzalex. So I'm glad to be off of that. Anyway, I'm very anxious to see. In my case, they're going to wait 8 weeks. I'm anxious to see what the results are.
I hope the best for you.
Thank you very much, and I appreciate your comments. And thank you for being here.
Thank you. We have just 2 more minutes. We could just take one more caller. Person calling in using 720-371-6410. You're on air. Please ask your question.
Oh, good morning. I am Nikki Temple, and appreciate your time and experience. What has been your experience with Darzalex and late-stage plastocytomas?
The question was not easy to hear, but I think it's the question is what is the experience with Darzalex and extramedullary plasmacytomas?
Yes.
Yes.
My expectation is that they will be sensitive to Darzalex.
Have you seen this in any trials at this point?
We do see patients responding, including patients with extramedullary disease, yes, and we can follow the extramedullary disease manifestations by CT scans, repeated CT scans, and we can see them disappearing, yes.
Thank you. I appreciate your efforts and thank you very much.
Thank you. It's almost our hour is up. Dr. Plesner, thank you very much for that informative session. Gary, Jack, and Cindy, thanks for your participation. This talk will be made available on Cure Talk's website along with its transcript. We will be continuing our talks on upcoming immunotherapies and myeloma with Dr. Saad Usmani in March. Please visit curetalks.com for details of upcoming talks. Thank you very much, everyone. Thanks a lot.
Thank you.
Thank you,
Bye-bye.
Doctor. You did a wonderful job.
Thank you very much. It was a great pleasure to be with you.